Good day to everyone who is sitting in on our webinar today. It's an honor for the four of us to present to you today. My name is Fred Apple. I'll be moderating this session. I am professor at the University of Minnesota in lab medicine and pathology, as well as one of the medical directors in the clinical laboratories at Hennepin Healthcare System at the university, in Minneapolis. So a little commercial here first. I chair the IFCC Committee of Clinical Application of Cardiac Biomarkers, in which all three speakers are part of. I'd just like to call to people's attention the third bullet, that in addition to the webinar, the IFCC is pleased to announce that they're making 3 courses on cardiovascular disease available to all participants. These are courses that are prepared by Dr. Liza and myself. You can read this documentation. It links to many other courses besides cardiovascular. And I think you all should take advantage of this opportunity and contact the IFCC with questions and how to do this. So I just show you our committee. The world has changed since one of our early live meetings in London, where we all sat in a conference room and talked and got to smile and break bread and have some drinks together. But now our committee meets almost every month virtually on a Zoom call. But yet we've maintained our activity and have continued our mission of education, in this case in the field of cardiac biomarkers. And I think today our speakers are going to be addressing what I see as a overall concept of how we use cardiac troponin, especially high sensitivity, across the board, looking at the role we always knew it as is diagnosis, using, in this case, sex-specific 99th percentile upper reference limits. We're going to hear about rule-out thresholds, which are lower than the 99th percentiles. And we're also going to hear about risk outcomes assessment, both above and below the 99th percentile, and the importance, I think, in the future of how to use troponin as a risk stratifying tool. I think we'll see this slide at least 1 or 2 times, but we're here talking about troponin, which has been refocused and defined by the universal definition of myocardial infarction as a marker of myocardial injury, of which many pathophysiological presence are there. This is a figure from the Universal Definition 2018 paper. I've added COVID-19 because we all have learned the importance of this as a measurement for both injury and risk. I also show a slide here. It's almost complete, up to date, of all regulatory approved high sensitivity assays, starting as early as 2007 for central laboratory assays, all the way to a recently CE marked novel whole blood point of care assay that is now used outside the United States worldwide. With this, we'll hear about improved analytics, early detection, risk stratification, early rule out. These are all very important changes that are really moving forward very fast and really good for patient care. And finally, not to me spend any more time, I'd like to introduce our first speaker. He's probably known to, like all speakers are to all of you, Professor Alan Jaffe from the Mayo Clinic in Rochester, Minnesota. Alan has been on the committee as a member for 6 years and now as a consultant. He's boarded in cardiology and also is one of the most knowledgeable cardiologists in the field when it comes to cardiac biomarkers. So now I'll turn the podium over to Alan.
Thank you, Fred. It's my pleasure to join all of you this morning. I just need to make sure the slides are visible. Are people able to see them?
Not yet, Alan. Did you make sure you share your slide? There we go. Okay. Now just open it. Yep. Full. Down in the lower right-hand corner, the show with the show. Lower right-hand corner of your screen, you'll have the little hat.
Yep. Yep. It isn't working. I'll stop sharing again. Start sharing again. Whoa. I'm not sure what I shared.
Click the first slide, Alan.
People able to see that?
No. Make sure your slides are open up, and then there's behind the screen, and then click it once, and you get it to the screen. So if you open your PowerPoint on its own,
it's open.
Then click on it so it comes up in front of this screen.
It's on.
No, we don't see your sharing, unfortunately. Go into the share box and hit share.
Entire screen window. Here we go.
There you go. Now hit the little box in the lower right of the screen. That'll bring it up. Upside down hat. There you go.
You want to swap these, right?
That's perfect. If that's what you got, don't mess around.
Good. Welcome. And I'm sorry it took us so long to get that done. But it's my pleasure to join you for this morning, evening, afternoon, or even midnight to talk about how to use troponin and how to think about myocardial injury, because often we think about myocardial infarction when we think about troponin. And as Fred showed you this slide from the universal definition of myocardial infarction that many of us were involved with, it's clear that there is an important role for troponin in the diagnosis of myocardial infarction. But the reason it is because troponin, an elevated troponin, detects myocardial injury. And I'll go through the various types in a moment. And in the appropriate setting, which we'll talk about in just a moment, then that may be myocardial infarction. However, one begins to look, and these are some recent data published in JACC from our own group, looking at the implementation of high sensitivity troponin T in our health system. The frequency of elevated troponins went up from basically about 15% to about 48%. And you can see the vast majority was not due to acute ischemic heart disease. There was only a modest increase. Now, this is not the case with every high sensitivity troponin implementation, but the reality is that as assays are becoming more and more sensitive, we will be finding more and more of what is called non-ischemic myocardial injury. This is reflected as well in this tabulation from some years ago when Europe moved to high sensitivity from the Sweetheart study. The vast majority of increases in detection of an elevated troponin were not associated with acute coronary syndromes. You can see the same modest effect we saw, but were associated with other cardiac diseases such as arrhythmias, heart failure, and the like, and many other non-cardiac primary diseases like sepsis and acute respiratory failure, which we will talk about. If you start to think about that then, and you think about it from the perspective of evaluating patients, this is a long follow-up set of data from Martin Than, John Pickering in Christchurch, New Zealand. And what you can see for both what we call MACE and cumulative death, that if you have very low values, I'm pointing now to the low yellow and red bars on the left and on the right, one with troponin I, one with troponin T. And on the right bar with troponin T, the blue bar is also within the normal range. You can see the prognosis is not terribly adverse. But when one has an elevated troponin, as shown in the upper three curves on the left and the upper two curves on the right, you can see there's a substantially adverse prognosis. So defining myocardial injury and what causes it is of some importance from the point of view of the prognosis of our patients, and therefore in and of itself deserves time and attention. Now, how should we think about this? Well, if you have a rise and a fall in troponin with a value above the 99th percentile, you have acute myocardial injury by definition. If you do not have clear, overt evidence of myocardial ischemia, then that's acute myocardial injury, not myocardial infarction. Some examples shown on the right. If, on the other hand, you have an unchanging pattern with elevated troponin values, you have what is termed as chronic myocardial injury. Some examples shown on the right. And as a rough guidepost, a lack of change of about 20% is a good way to define whether or not there's a changing or unchanging pattern. Finally, if you have acute myocardial injury, as shown on the left, and you have symptoms, ECG changes, evidence that imaging or coronary angiography that tells you that the reason for the increases are due to ischemic heart disease, that's when you have acute myocardial infarction. And as I showed you when we started, this is a relatively modest percentage of the number of increases that are seen. So how should one think about it? This is another graph from the universal definition. Again, if you have an elevated troponin and a rise and a fall, if it's with acute ischemia, you have acute myocardial infarction. And there are, and it's worthy of an independent discussion, ways of distinguishing between type 1 and type 2 MIs. On the other hand, if you don't have acute ischemia, you have acute myocardial injury. And if the values are stable, chronic myocardial injury. Now, it's pretty important, I think, clinically, if I put on my clinical ischemic heart disease hat for a moment, to try and make some decisions pre-hoc about what you think is going on, so that it is your clinical impression that drives the evaluation of the troponin and how it affects your thinking about a given patient, rather than having the troponin alone guide your thinking. This slide comes from the appraised group. I would suggest for now we can ignore the numbers. The principle is what is important. If ischemia is unlikely in a given patient, the fact that a troponin may be elevated doesn't make the likely post-test probability terribly high. The higher the value, the higher the probability, but nonetheless, still, if ischemia is unlikely, you should be thinking of other etiologies for myocardial injury. The same thing exists for the intermediate probability, and in circumstances where you're sure that ischemia is present clinically, then an elevated troponin, even before you see the change, which you will eventually document, may be sufficient to take action based on a diagnosis of myocardial infarction. The reason this is so important is that so often clinically, the troponin comes back before the clinician has decided how he or she thinks about the clinical presentation. And then sometimes one is chasing the troponin rather than inculcating it as part of the diagnostic algorithm. Just some examples of myocardial injury that is often, not never, but often due to myocardial injury and not ischemic: heart failure, myocarditis, cardiomyopathies, Takasubos, some cardiac revascularization situations, defibrillator shocks, contusion, and catheter ablation. Some other causes, not with a primary underlying cardiovascular abnormality, include things like sepsis, chronic kidney disease, stroke, pulmonary embolism, infiltrative disease, drug toxicity, critically ill patients, and strenuous activity. One of the things that confounds clinicians a bit, and so I want to take a few minutes just to discuss some of the causes of myocardial injury, because sometimes people say, well, what are we really talking about? Well, here's one example. If one infuses dobutamine, which we do all the time for diagnostic purposes, one will see that when one has inducible coronary artery disease, the troponin goes up. When one has non-inducible coronary artery disease, but also even in normals, troponin goes up a bit. Why? Because catecholamines, by their very nature, are myocardial toxins. Now, this is not a problem for a true normal whose value may or may not at some point in time exceed the 99th percentile. But remember, dobutamine is used to evaluate all kinds of people. And these small elevations may, in a given patient, cause increases above the 99th percentile. And then one could be confused if one is not aware that dobutamine will do this. This is rapid atrial pacing. Whether one has an elevated coronary artery disease and an elevated lactate, or coronary artery disease, not an elevated lactate. But even if you don't have coronary artery disease and you don't have an elevated lactate, there are modest changes that can occur. As a matter of fact, we're at a point where we need to be very careful, because some of what some might call normal physiology is beginning to impact on some of our diagnostic accuracy. I won't show you, but similar things occur in patients who exercise and have elevations. One mechanism that may be related to that is shown here. This is an experimental study, but it looks at what happens if one acutely increases preload in an experimental animal. And what you see is that troponin is proteolyzed and released. This is a non-high sensitivity assay. And the cells eventually die due to apoptosis. This is probably a very common mechanism in heart failure patients and in patients with end-stage renal disease who are on dialysis. Something similar occurs with brief periods of ischemia, as short as 10 minutes in this particular experimental example. And again, the cells do not have necrosis. They die due to apoptosis. These are data in heart failure patients. When you say, gee, a lot of heart failure patients have elevated troponins. Why is that? Well, one reason is that many of those patients have microvascular dysfunction. And if one characterizes those patients, as in this study from Japan, you can see that there are more increases in those who have microvascular dysfunction than in those who do not. Stress in and of itself, and we could argue what stress is, can cause similarly modest elevations. This is a study which several of us did in a cohort of orthopedic surgery patients under the age of 40 undergoing elective surgery. What you can see is that there's some modest changes. Now, these changes in only one instance rose above the 99th percentile. But again, for patients who maybe started at a higher value because they have an underlying cardiovascular comorbidity, as I suspect Dr. Omland will talk to you about later, might well have values well above the 99th percentile. So it is terribly important to begin to understand that how to think about myocardial injury and distinguish it from type 1 MI, which is shown here, and from type 2 MI, the criteria of which are shown here as well. Often, there is not much difficulty in diagnosing a spontaneous myocardial infarction, in particular if it's a STEMI. Some non-STEMIs can be more problematic. But there often is difficulty distinguishing type 2 MI that could be secondary to supply-demand imbalance and therefore ischemia from other causes of myocardial injury that we just talked about. Is it important to do so? Well, we'll get to that in just a moment. Just to be sure, what we're talking about now are not the non-thrombotic coronary etiologies of type 1 MI. What we're talking about are the frequent patients, as shown in this tabulation from SABI, who come in and who are anemic, respiratory failure, have arrhythmias, who have rapid heart rates, low blood pressures. And if you think about these, most of them have not just one abnormality of supply or demand, but usually have two. If indeed you're anemic, you have usually compensatory tachycardia and volume overload. But the compensatory tachycardia and volume overload also causes shortening of diastolic filling and therefore reduced coronary perfusion, and causes increased pressures within the ventricle and therefore reduces subendocardial perfusion. So they're both. So these are the sorts of patients in whom one could worry and say, this person has tachycardia or hypotension. Even though I don't see ischemia, it must be an ischemic mechanism. And there's several reasons why that sort of thinking can at times be problematic. And COVID is one of them. This is a tabulation that several of us made for the European Heart Journal. And what's listed here are some of the causes of myocardial injury in the COVID population. And in yellow, those are uncommon causes. The common causes are in orange: organ failure, pre-existing disease, direct myocardial injury. And there are a whole bunch of others that are very common in COVID and probably in individual patients play a role. They can be septic, they can have pulmonary hypertension, and they can have this endothelitis with involvement of the microvasculature and actually thrombosis in that area that can be terribly important. So troponin, not surprisingly, is prognostic in this setting. And similarly, if one looks, one also has a signal if one has a changing pattern with more acute injury, increasing the mortality. Well, here's the information that I think is of some importance. This is a tabulation done by a young cardiologist named Yader Sandoval, working with somebody up in Hennepin County, I think his name was Apple, in which they looked at patients who had type 2 MI, possibly. And they took a very rigorous approach to defining who had type 2 MI and who had myocardial injury, and insisted that there had to be objective information. So you see the tabulation of objective type 2 MI versus myocardial injury. What you can see is there appears to be at least a trend toward the patients who had the objective type 2 MI to do worse, likely because they are enriched with patients with coronary disease. Now, not everybody with type 2 MI has coronary disease, but if one doesn't carefully separate out those who really had subjective ischemia, and in particularly at a lower ischemic threshold, one will miss this sort of opportunity because these patients probably are a higher risk subset than the rest. This is the tendency that people have to do in patients with acute respiratory failure, where we know there's a lot of coronary disease because many of these patients are smokers, and they clearly have an abnormal prognosis if their troponins are elevated, but acutely, it's not so clear that very many of them, given the way we understand the data now, are having myocardial infarctions. What is important, however, is that even though you're not necessarily going to intervene on somebody during the acute setting, as shown on the left, once these people go home, they've unmasked the fact that they have underlying cardiovascular disease and an adverse prognosis. And that's when I would argue we as clinicians should be more astute and more interested in evaluating the causation. This is also the case in patients who have GI bleeding and in patients who have sepsis. So all of these critically ill patients don't have type 2 MI. The vast majority have myocardial injury. And if we think about it as myocardial injury, we can begin to probe what those mechanisms are. And by probing those mechanisms, and eventually we might be able to figure out whether or not there are additional therapeutic approaches we might employ. So a colleague, Giori Landesberg, who's from Israel, and I were looking at the relationship of high sensitivity troponin T to survival in septic patients. And what we found was a relationship. Then we asked the question, what is the relationship functionally and anatomically and structurally of an elevated troponin to the clinical substrate of the patient? And this is a complicated slide, which I won't take you through, except to show you that what we found eventually, and we'll explore this in a moment to a greater extent, was that patients who had an elevated troponin tended to have more diastolic abnormalities. So what Landesberg and colleagues then did was to do 250 consecutive patients who were septic and look at the relationship between diastolic function and an elevated troponin, and were able to show that the best association between an elevated troponin and diastolic and in septic patients was not only diastolic abnormalities, but an enlarged RV, suggesting that the problem of hydrating these patients, which we had also seen in the prior study, that somehow those patients were not as easy to volume expand, may well be due to a functional abnormality that could be contributed to with tachycardia as well, because tachycardia shortens diastolic filling. Interestingly, if you start going back to the literature, there's some straws in the wind about things that might affect diastolic function. So this is simply a tabulation of patients who came in with sepsis. And it turns out if they were on beta blockers, they did slightly better. Certainly not worse, as you would expect if this was a primary contractile problem. In an experimental model, although they're modest reductions in blood pressure in septic models, it's clear that the major effect is in heart rate, and that one can, at least in experimental models, provide beta blockade without causing hemodynamic abnormalities that are severe. If one looks in that same model and looks at the effects on TNF, which is one of the cytokines and heat shock proteins that is elaborated during sepsis and is thought to play an adverse role, you can see that they're reduced, so that there is some benefit biologically of doing so. If you then look at some of the heat shock proteins in sepsis, interestingly enough, one that is protected, heat shock protein 1, actually goes up in lung, suggesting that it might well be a good idea to slow heart rate and give beta blockers. In that particular study, it turned out that the beta blocker group did better. Now, the only way one would come to this sort of evaluation would be if one were willing to think outside the box and to not accept the fact that because there's tachycardia, hypotension, hypertension, that this has to be supply-demand imbalance. The only way to move forward in any area is by challenging convention. I'm not here to advocate for beta blockers in everybody with sepsis. However, the thought of trying to slow heart rate as an intervention in sepsis is one that I think is worth considering based on the data. But it only comes if we embrace this idea of myocardial injury, distinguish it from ischemic myocardial injury, and begin to study it in a more comprehensive way. Thank you very much.
Thank you, Alan, very much. You can unshare your slides now. And I just want to remind the audience, please, if you have questions, because we're going to have the Q&A after, to send in your questions so we can review them and answer them. So at this point, we are honored to have Professor Rick Brodie. Rick is from Manchester, UK, and he's going to be discussing early rule-out protocols. Professor of emergency medicine. You can see today we have both laboratory, emergency medicine, and cardiology covered. So Rick, thank you for being here, and don't forget to do all the things you need to do to show your face and share your slides.
Thanks very much indeed, Fred. Hopefully you can hear me okay, and hopefully in a few moments you'll be able to see some slides.
Perfect. Thank you.
Great. So let's bring those up, and you'll hopefully see them full screen in a moment. So I won't be able to see you now, but hopefully you can see my slides. So thanks for the kind introduction, Fred. It's been a pleasure to work with Fred and the group in the IFCC CCB for the last few years. I work in the emergency department in the UK, and I'm going to talk about rapid rule out in particular of acute myocardial infarction and why that's important and how we can do that in an evidence-based way. So first of all, let's think about the scale of the problem that we have with suspected cardiac chest pain in the emergency department. So patients who present with chest pain go on to represent around a quarter of all of the people that we admit to the hospital for acute medical reasons. It's the most common reason for acute admission to hospital. And despite the fact that we admit so many patients, only a small minority of them actually have the diagnosis that we suspected, an acute coronary syndrome. Most of those patients that are admitted are only there for diagnostics. So if we could do better with the diagnostics, we could avoid a whole lot of unnecessary admissions. And with the pressures on our urgent care system right now, we could really do with that help. And high sensitivity troponin will allow us to do that. Just to emphasize why this is important for our patients, This slide just summarizes some data from a big study in the US, which looked at the impact of emergency department crowding on mortality. Now, crowding is a growing problem in emergency departments. We're really struggling in the UK. Attendances are going up year on year, and patients are staying for longer because they can't get out of the department because there are no beds in the hospital. And here in this study, which is one of many that have shown something similar, the authors demonstrated that periods of crowding in the ED were associated with higher mortality, even after adjustment for the diagnosis at discharge and key comorbidities. It was associated with a higher length of stay, a longer length of stay in the hospital, and it was associated with higher costs, healthcare costs. In the UK, we had a study published only around about a month ago, which looked at the association between 30-day mortality and length of stay in the emergency department. Patients who waited in the emergency department for more than 4 hours had increased mortality rates, and that mortality rate, standardized mortality rate, progressively increased the longer you stayed in after 4 hours in the emergency department. So it's really important that we make fast decisions for our patients. The ones who can go home, we should get them home. The ones who need admission, we need to get them into beds quickly, and that means freeing up the beds for them to go into. It's really important for mortality, for patient safety. Now, when we treat patients with suspected cardiac chest pain in the emergency department, we have a big problem because many patients present with typical symptoms and they're not having an acute myocardial infarction. It's like they've read the textbook. They'll come in with central crushing chest pain, radiating to the left arm. They'll be vomiting. They may have been sweating, but they won't be having an acute myocardial infarction. And then similarly, you'll see someone else who's young, who has very atypical symptoms, who has only had a few minutes of chest pain, and their troponins will rise massively and they'll have had an end STEMI, and you just couldn't guess it. This data here from Ed Carlton, who was in Bristol, articulated this problem very nicely. So he asked the doctors to classify patients' symptoms as either typical or atypical for acute coronary syndrome when they were in the emergency department. And he's plotted here the sensitivity and specificity for all physicians, for experienced physicians, and for novices. And you can see sensitivity in the dark grey bars is very, very low. It's around about 50%, and even lower for experienced physicians. The specificity was really no better. The symptoms really don't get you that far. They get you as far as understanding that you need to rule out acute myocardial infarction, but no further. And it's the same story for the patient's past history. We've looked, for example, at the Framingham risk factors: hypertension, hyperlipidemia, diabetes, family history, tobacco smoking. The more risk factors a patient has for cardiovascular disease, you might think the more likely it is that they have an acute coronary syndrome. In fact, that's not true. So we looked at this a while ago in 2012. In the blue bars here, you can see the prevalence of myocardial infarction in patients attending in the emergency department, stratified by the number of Framingham risk factors that they have. And you can see very little association with a growing risk factor burden. And we repeated that more recently last year. And you can see again, this time more of an association. There is a trend to increasing prevalence of MI with increasing risk factor burden, but you're not going to rule in or rule out. Look at this, you're still at less than 25% with 4 or 5 risk factors. And with 0 risk factors, there's still a 9% chance of an acute myocardial infarction. So the patient's history, unfortunately, isn't going to get us very far. And the ECG is very similar. Here are the ROC curves for risk factors, and you couldn't get worse ROC curves if you tried. So just to prove the point, you can't rely on them. We need to rely on the biomarkers. We need to rely on cardiac troponin. Now, we're very lucky now that we have high sensitivity cardiac troponin assays. Just to quickly illustrate what a high sensitivity assay does. Previously, before we had high sense troponin, the limit of detection of the cardiac troponin assays was roughly at the level of the 99th percentile, meaning that we couldn't really detect cardiac troponin in apparently healthy individuals. And we couldn't measure these concentrations at the 99th percentile very precisely either. The coefficient of variation didn't get to below 10%, which we need for diagnostic purposes, until you got to a concentration way above the 99th percentile. With high sensitivity assays, we address that. So the limit of detection is way below the 99th percentile upper reference limit. And that means that we can detect troponin concentrations in a whole spectrum of healthy individuals, more than half of healthy individuals. And we've got great precision. So the coefficient of variation reaches 10% or below way below the 99th percentile. So we can precisely measure small troponin concentrations. That means we can recognize small changes. That means we can use a lower threshold to rule out acute myocardial infarction in patients when they present to the emergency department. Imagine you're having a myocardial infarction. Hope that never happens. Soon after the infarction starts, the troponin concentration is going to start rising in your blood. If you put the threshold down really low, it's going to take you less long to pass that threshold than if you wait for it to get above this higher threshold at the 99th percentile. With high sensitivity troponins, we can set that threshold really low. And if patients haven't surpassed it at the time of arrival, maybe we could rule out with one test. Well, the evidence strongly suggests that indeed we can do that. We've got great evidence. This is just a selection of a few of the studies that have validated using low troponin cutoffs with high sensitivity assays at the point patients first arrive in the emergency department. So with the Roche troponin TSA, there are numerous studies. This is TRAPID AMI, a multi-center study in, I think, 12 countries. And the cutoff set here at 5 nanograms per litre, the limit of detection of the assay. We get a great sensitivity, over a third ruled out. We've got similar evidence for the Abbott assay. This is at the LOD, 1.2 nanograms per litre. There is other evidence, particularly from Edinburgh, going up to 5 nanograms per litre, showing a pretty good, well, excellent negative predictive value for sure. Beckman Coulter, same with their high sensitivity assay. Siemens Healthineers, the same with their high sensitivity assay. We've got loads of data to show that you can reliably, accurately rule out acute myocardial infarction with one test when patients first arrive in the emergency department, using a high sense assay, setting the cutoff at or around the limit of detection with a well-validated cutoff. For those patients you can't rule out, we can do the second test very early. So this is where precision comes in. We can recognize small changes with high sensitivity troponin. You get, because of the better precision, you're less likely to get analytical variation at those small concentrations. You're less likely to see small deltas just by chance. And we can set these small delta criteria for changes on serial sampling across just 1 hour. And we've got very, very well validated 0-1 hour pathway in the European Society of Cardiology guidelines, which suggests that for those patients who haven't been ruled out with the first test, we do the second one an hour later. And if your first threshold is at a low cutoff, maybe just below the 99th percentile, and there's a very small delta, then you're ruled out. And similarly, we can rule patients in if they've got a high initial concentration or a high delta. So this is great. This is really going to help us in the emergency department. We can suddenly unburden those crowded places, get patients straight home, don't need to necessarily admit them. Fantastic news. The only difficulty is it's not quite that simple. You have to do a bit of work on implementation. And I know that because there are 2 randomized controlled trials that tell us that we have to do a bit of work. So the loaded trial, limit of detection and emergency department trial, was led again by Ed Carlton, published in Heart a year or so ago. And they randomized patients, 629 of them, who had normal ECG, to either standard care, and the local pathway was used in that case, or the intervention group. In the intervention group, they said that if your troponin is below the limit of detection, then you can go home, straight home. And the primary outcome they were looking at was discharge within 4 hours, provided that the patient didn't come back with a major adverse cardiac event in the next month. Now, you might think, no brainer, this is obviously going to work. We've got loads of observational data showing the accuracy. Actually, they showed no significant difference between the 2 groups. So there's slightly more patients here discharged in the intervention group, 46% versus 37%. But the odds ratio had confidence intervals that crossed 1. So it wasn't significant. It was a negative trial. They didn't successfully show an increase in safe discharges. Does it mean we shouldn't use that strategy in practice? No, it just highlights that actually making it work in your emergency department is not easy. You're going to have to do a bit of work on implementation to get the pathway right, to make sure people are following it, to give them confidence to follow it. Otherwise, you're not going to see the effects. Then we've got the historic trial from Edinburgh, which was published very recently. This was slightly different, whereas in Loaded, they randomized individual patients. In Historic, they did a step wedge trial, so everyone starts in the control group, and then they moved across to the intervention group. And in the intervention group, they used the Abbott troponin and ruled out if the troponin was less than 5 on arrival. Now, in this study, we've got slightly different findings. The length of stay went down successfully, so that's great news. They did successfully shorten the length of stay by a few hours here. And more patients were discharged from the ED without being admitted to inpatient areas. So great. In this study, we see a reduction in resource use. However, it was also a negative trial because the primary outcome was non-inferiority for safety outcomes, MI or death at 30 days. And they didn't quite show that. So, do you say, well, look, we've got 2 negative RCTs, we shouldn't use this strategy? Actually, there's no suggestion it was more harmful. It just didn't quite meet the predefined non-inferiority criteria, and it was more efficient. We've got loads of observational data. What I think these trials show is that you've got to work hard on how you implement the strategies, but there's absolutely no reason why we shouldn't be using them in emergency departments. So what about risk scores and clinical decision aids? In the emergency department, we love these. We love having flowcharts that are simple like this on the left because it tells us exactly what to do. We love using the Wells score to rule out pulmonary embolism or deep vein thrombosis because they're dead easy and it tells us quite clearly what we should do with our patients. And we've got them for patients with suspected acute coronary syndromes. We've got the heart score. It's very, very widely used. It's dead simple. Everyone loves it because heart spells out history, ECG, age, risk factors, and troponin. You score each of them from 0 to 2. And based on the score, it tells you whether the patient can go home or not, which is fantastic. So lots of places use it. Question is, do you need it when you've got such great 0-1 algorithm pathways that are already well established? And then we've got TMAX. So we developed that in Manchester. TMAX combines the history, ECG, and the troponin in an evidence-based way using multivariate analysis. And we calculate the probability that a patient has an acute coronary syndrome to put them into 4 groups: rule in, rule out, and then 2 in the middle. So let me just tell you a little bit about TMAX and why we decided to use that. So just a couple of principles here. First one is that troponin is a continuous variable. So, we use these thresholds and they're great because they're very clear and they're simple and we know what to do. But actually, the lower your troponin, the better it is for the patients. This is evidence from our first study years ago, where we show the prevalence of MI stratified by their initial troponin concentration. And you can see it goes from 0 to 100 based on that troponin concentration. If you impose any cutoff, you make this much more simple, but you lose the granularity and some of the detail. Actually, we can work out probabilities based on this, can't we? It's a continuous variable. The higher troponin, the more likely it is an acute myocardial infarction. And we took advantage of that in TMAX when we calculate this probability. Here's how it worked. We validated it and showed that it's got great rule out. This is a proportion of patients with MI in each risk group for TMAX and heart in pink. It goes up, so it risk stratifies through the risk groups, and we get really good positive predictive value to rule in. 47% of people going home after 1 test, and that's more than if we just used a troponin on arrival at the limit of detection. So if we just use the troponin at 0 hours, we get 29% home. If we use TMAX, we get 47% home. Same sensitivity and negative predictive value. So it does add some value there. And the other thing is, one other reason to use a decision aid like TMAX or heart or EDAX is we got to direct patient flow. So to unburden that ED, we want to move people on once we've seen them in the ED to another area. And this allows us to do that, even if we're waiting for results, even if it's just the 1 hour result. So it allows us to send our low risk patients to an ambulatory care unit. We still use it with a 0-1, well, in our case, 0-3 hour protocol. You don't bin those troponin algorithms, you still use them alongside the decision aid, and you use a decision aid to guide flow. So what about patients in the middle? So we've got great rule out, we've got great rule in with the 0-1 hour algorithm. What do we do in this observation zone in the middle? Because we've got this troublesome observation zone. I just want to say a few words on that. How do we resolve the uncertainty? So let's say you've been through the 0-1 algorithm, you're still in the observation zone. What should you do? Well, I think I'd do first is repeat that troponin again, 3 or 6 hours, rule out an acute myocardial infarction, make sure that it's not going to go up because you've not ruled in, you've not ruled out. If the troponin stays below the 99th percentile, you've ruled out acute myocardial infarction. Rare cases, if the trend is going upwards and you're just below the 99th percentile and you're really, really convinced this clinical context is concerning, you might do another troponin. But in general, if you followed a validated rule-out pathway and the troponin is below the 99th percentile, you can consider myocardial infarction ruled out. If you've got 1 troponin concentration above the 99th percentile, then we need to know, as Alan said, is there a change? So is there a rise or fall? So traditionally we use 20%. There's some evidence, convincing evidence now that an absolute change in troponin values is actually more accurate than a relative change. And some suggestion that as a rule of thumb, about half the 99th percentile is your significant delta. So if your 99th percentile is 14, a change of 7 is significant at 3 hours. And that's because if you have a relative delta, it biases you towards diagnosing small MIs, like this patient who goes from 10 to 15 or vice versa, gives you 50%, and against the big ones. So if you start at 2,000 and go to 2,200, that's only 10%, whereas absolute delta recognizes that change. So here we go. This is what to do. If you've got one troponin above the 99th percentile, is there a delta? If not, just like Alan said, it's chronic myocardial infarction. You can rule out an acute MI. Bad long-term prognosis, but it's not an MI. If you've got a significant delta, does the clinical context fit within a myocardial infarction? If it does, then that's what you've got. If it doesn't, then we're still in another grey zone. And that's where we have to think carefully about what Alan has talked about in great depth, very helpfully. These conditions, we need to differentiate type 1 AMI, where you've got the clinical context, you've got signs of ischemia, you've got the troponin rise or fall, and you've got nothing else that's caused it. Type 2 MI, where you've still got the tight signs of ischemia, you've got the troponin rise or fall, and you have something else that's caused it, so that's put strain on your system. And then acute myocardial infarction, where you've got the troponin rise and fall, but you've got no signs of myocardial ischemia. Okay, so that was a whistle-stop tour through what we do in the emergency department to rule in and rule out myocardial infarction. In summary, rapid rule out of myocardial infarction is really important because it's going to help us to unburden our crowded emergency departments and address the consequences of that, including higher patient mortality. We should be using the 0-1 or 0-1 to 3 hour algorithms at very least, with validated pathways, and a decision aid may help you to direct patient flow and potentially gain further efficiencies. Interpret the clinical context and the delta, and that's really important because that will, only by doing that can we differentiate type 1 MI from type 2 MI and acute myocardial injury from chronic myocardial injury. Thank you very much.
Eric, thank you so much for that great presentation. Just let the audience know we're going to, again, hold questions till after our last speaker. I'll moderate them and encourage everyone to direct questions at individual speakers, or the group will address the questions. So our last, quote, global leader today is a friend and a committee member of our group, committee on the IFCC committee, Professor Troponin Omland from Norway. He is a professor of medicine, known in the cardiology world in acute coronary syndrome and heart failure, and a consultant cardiologist at Akershus, if I got that right, University Hospital. Troponin, the web is yours.
Can you see my screen?
I think you have to open your slides. There we go. And then full show. Perfect.
Okay. Thank you for that kind introduction, Fred. I've been asked to speak about diagnosis and risk assessment. These are my disclosures. I've worked with several companies that manufacture high-sensitivity troponin assays. So I would like to convey sort of the 4 key points during this talk. And the first one, it will be sort of a reiteration of some of the points that both Alan and Rick have already made. It's about that an acute rise and or fall of cardiac troponins in blood in the setting of myocardial ischemia is essential for diagnosing myocardial infarction. And that is, of course, derived from this document, the 4th universal definition of myocardial infarction that was published in the latest version in 2018. So just to reiterate this very important points that myocardial injury is defined alone by an elevated cardiac troponin T or I value above the 99th percentile URL. And if there is a rise and or fall of the cardiac troponin values, the injury is considered acute. Whereas the definition of myocardial infarction is more strict. It denotes the presence of acute myocardial injury as defined below in the setting of evidence of acute myocardial ischemia. And as Rick also alluded to, there has been a tremendous development of cardiac troponin assays. And this has had real clinical applications, and especially with the introduction of the high sensitivity assays. And sort of the whole definition of the fourth the fourth universal definition relies on the use of high sensitivity assays, so that we are able to measure troponins with high precision, and also so that we are able to clearly define the 99th percentile and can detect very small delta changes. And the definition of a high sensitivity assay is, as you know, the ability to detect cardiac troponins in more than 50% of healthy individuals, and that means both more than 50% of women and more than 50% of men. And of course, the detection of delta is crucial, and what we are looking for is a delta that must exceed the natural biological variation of cardiac troponins. And as Rick pointed to, we have previously used a relative change, 20% if the value was higher than the 99th percentile. But there is increasing evidence, and I support his view that absolute delta changes probably are more accurate and more useful. So just to reiterate sort of the criteria and the distinction between a type 1 and a type 2 myocardial infarction. So the type 1 is sort of the spontaneous atrothrombotic kind of myocardial infarction, which is based on a plaque rupture or erosion with an occlusive or non-occlusive thrombus formation. So we need to diagnose a type 1 infarct to have the rise and or fall of cardiac troponins, one value at least above the 99th percentile, and then combined with other findings that are suggestive of myocardial ischemia, that be symptoms, electrocardiographic changes, or imaging changes that support the criteria or the criterion for the presence of myocardial ischemia as the cause of the troponin elevation. So for the type 2 myocardial infarction, the underlying pathophysiology is different. It's generally based on a mismatch or an imbalance between oxygen supply and demand, and it can be caused by many different clinical situations. It could be due to prior coronary artery disease. It could be due to vasospasm or microvascular dysfunction. It could be, in rare instances, be a non-atherosclerotic coronary dissection, or it could be clinical conditions where there is oxygen supply demand imbalance alone, as long-standing tachycardia, or we can also see in sepsis, as Alan was discussing. So the criteria for a type 2 myocardial infarction is, again, the detection, the sine qua non criterion of a rise and or fall of cardiac troponin, one value at least above the 99th percentile, and then evidence on imbalance between myocardial oxygen supply and demand, and it should be unrelated to atherothrombosis. But still, it requires additional criteria, one of the following symptoms of acute myocardial ischemia, new ischemic ECG changes or pathological Q wave development, or imaging evidence of loss of viable myocardium. So if a patient presents then with an elevated cardiac troponin value above the 99th percentile, and there's serial measurement being performed, we can classify the patients according whether the troponin levels are stable or whether there is a rise and fall pattern. And if there's a rise and fall pattern, we will classify according to the presence or absence of ischemia. And if there is ischemia, acute myocardial infarction is diagnosed, and we will tried to classify it as a type 1 with atherosclerosis and thrombosis, or the oxygen supply and demand imbalance, a type 2 MI. If there is no evidence of ischemia, we diagnose acute myocardial injury, and examples of that may be conditions like myocarditis or acute heart failure. And in the case of a stable troponin levels, chronic, above the 99th percentile, chronic myocardial injury is diagnosed. So the second point I would like to make is the relationship between troponin thresholds, troponin kinetics, and that they probably have a limited value for actually distinguishing between myocardial injury and myocardial infarction. So this slide shows sort of the relationship between troponin concentrations and the positive predictive value of myocardial or for myocardial infarction. And as we have heard, there are multiple conditions that may be associated with troponin elevation. Most of these conditions will result in relatively mild or moderate increases in cardiac troponins, whereas the very high troponin levels are more frequently observed in acute myocardial infarctions. Sometimes in other conditions like myocarditis, but that's much more rare. So the question is then, and these are slides I've received from my good friend and colleague, Professor Nick Mills at University of Edinburgh, who is the PI of the high stakes trial. And they have done some very interesting analysis regarding diagnostic thresholds or troponin kinetics, and whether they will be helpful in differentiating between myocardial injury and myocardial infarction. So, and they've looked at different thresholds. So obviously, if you increase the threshold, and here they have used the 5-fold, the URL, and the positive predictive value will increase. But the difference is relatively modest, particularly if applied in all consecutive patients with suspected acute coronary syndrome, including in those in whom chest pain is not the primary complaint. And of course, the increased positive predictive value comes at a cost. The sensitivity falls substantially from 78% using the 99th percentile at presentation to 43% using a threshold that is 5 times higher than the URL. So what about the delta values? It seems logical that maybe type 1 infarctions will have greater deltas than a type 2 or an acute myocardial injury. And again, Ryan Veresky and colleagues working in Dr. Mills' group has looked into that in this paper that I strongly recommend, published in Circulation last year. And actually, here are the Violin plots of the absolute troponin change, and it is a logarithmic scale. But as you can appreciate, there is a very substantial overlap between type 1, type 2, and acute myocardial injury. And what these authors conclude is that you really can't draw any strong conclusions in most patients based on the delta change. However, of course, because that's part of the definition, patients with chronic myocardial injury will have a very different and much lower range of distribution of the delta values. So let's move to cardiac troponins and the prognostic value of these in patients who do not present with acute myocardial infarction. And what the point I would like to make is that stable low-grade elevation of cardiac troponins is associated with subclinical cardiac injury, and there's this particularly strong association with the risk of future heart failure and death. So if we look at patients with chronic coronary syndromes, we know that some patients will have an episode with an acute coronary syndrome, and then they will have their stent and their antithrombotic treatment and antiplatelet treatment, and they will have a very beneficial course, and they will live long without symptoms or any reoccurrence of acute coronary syndromes, whereas other patients will have a much more malignant course. So there is, of course, a great interest in early risk stratification to identify these high-risk patients so that they can receive intensified appropriate treatment. So back in 2009, I was fortunate to be able to measure, in combination with a great team of investigators from the PEACE trial. We used a prototype of the 5th generation Troponin T assay. And whereas in the earlier studies in the general population, maybe 1 or 2% of people would have detectable levels of cardiac troponin T. In this stable cohort of patients with chronic coronary disease without heart failure, and we could have detectable levels in more than 90%. And what was astonishing and very new to us at that time was that we could observe an association with cardiovascular risk, with the risk of cardiovascular mortality, taking off at very, very low levels. So actually, we could observe an increase in risk far within the normal range, starting maybe at 5, 6, or 7 nanograms per liter. And this is just to display these data another way. If we divide the patients into quartile, those in the 4th quartile, the upper 25% of troponin values, had a very worse prognosis than those in the lower 3 quartiles. And this was tabulated for cardiovascular death, and similar curves were observed for heart failure. And again, you can appreciate that even in the 4th quartiles, there were patients who had troponin levels within the normal range. Men, the cutoff for the 4th quartile started at 9.6, and for women at 7. So we observed very strong associations with the incidence of cardiovascular death and heart failure, and these were maintained also when we adjusted for multiple other risk factors in a multivariable model. However, what came to a surprise to us at that time was that the association with recurrent ischemic events with a new myocardial infarction was not as strong, and actually in the adjusted model was no longer significant. We also had the opportunity to measure high sensitivity troponin I using the Abbott assay in this cohort, and published that in JACC a few years later. And a very similar pattern here is the outcome cardiovascular death or heart failure. When divided into quartiles, a very strong and graded association with risk according to troponin concentrations. And again, the 4th quartile included patients within the normal range. The cutoff for the 4th quartile was 7 in men and 6 in women. And also there has been several studies later studying the prognostic value in the general population. And this is a study we did in the HUNT study, a large Norwegian epidemiological study, where we measured high sensitivity troponin I in more than 9,000 participants. And again, when the troponin I was divided into tertiles, a very strong and graded association with risk. Or actually, they were divided by selected cutoffs for the lower curve is 4 and 6, and then 4 to 10 and 6 to 12 for the intermediate, and about 10 and about 12 for the last curve. If we did the same for CRP, we did see an association, but as you can appreciate, it's not as strong or pronounced as for cardiac troponin I. We also observed interesting patterns with regard to the prognostic value when we stratified according to sex. And we already knew, and we learned from the P study and many other studies, that men in general have higher levels of cardiac troponins than women. But whether that had prognostic implications were not really clear. But in the Hunt study, we observed that women actually had a higher prognostic value, a better prognostic value than men, and that translated in a significantly greater area under the ROC curve in women than in men. And this has subsequently also been replicated in one of the Scottish studies led by Navid Sattar. So what about patients who present in the emergency department who are ruled out for myocardial infarction and have stable cardiac troponin levels or levels below the 99th percentile? And this is a study, again, by Sandoval, and this is from Fred's Utopia study. And it also showed very interesting data. And when these patients were stratified according whether they had levels below or above the level of detection of the assay, all patients had levels below the 99th percentile, but if you stratified according to the LOD, there was also a highly significant difference. So that patients with levels presenting in the emergency department and had levels within the normal range, if that was over the level of detection, the risk for new events was much higher than those with low levels or levels below the level of detection. So, of course, it's good to know whether there is an association with prognosis, but it really becomes clinically helpful if we have interventions that can actually modify troponin levels and actually can modify risk. So one important question is whether troponin concentrations can be modified with therapeutic interventions and whether that change is associated with change in risk. And it appears to be like that. In the interest of time, I don't have the possibility to show many studies, but I've selected these data from the VOSCOPS study, a statin study from west of Scotland. And in this study, pravastatin was, or patients were randomized to pravastatin or placebo. And it turned out that there was, in this population as well, a strong association between troponin I levels measured with a high sensitivity assay and the incidence of myocardial infarction or coronary heart disease death. It also proved that pravastatin reduced troponin I, and in fact doubled the number of men whose troponin I fell by more than 25%. And if you looked at this group, they had a 5-fold greater reduction in coronary events than in patients who had an increase in cardiac troponins. So again, sort of showing that it is useful to do serial monitoring also in the primary and secondary prevention setting. So I will just sum up my key points to end. And they are that an acute rise or fall of cardiac troponin in the setting of myocardial ischemia is essential for diagnosing myocardial infarction, and that cardiac troponin thresholds and kinetics have limited value for differentiating between myocardial infarction and myocardial injury, and that stable low-grade elevation of cardiac troponins is associated with subclinical cardiac injury and is particularly strongly associated with future risk of heart failure and death. And that fortunately, it seems like cardiac troponin concentrations may be modified by therapeutic interventions, and that change in cardiac troponin reflect this change in risk. So thank you for your attention.
Thanks, Torbjorn. Great presentation. I guess I'd like to ask all the speakers if they stop sharing anything and everyone gets back on, both video and audio. And I'll start the questions. I think we've got about 20 minutes to address some questions with everyone. I'm going to ask the first question. I'll address it to Dr. Jaffe, but I'd like everyone's opinion if you want. One of the questions had to do with how frequently do you see a positive electrocardiogram, let's say an ST segment elevation, in which the troponin is normal, less than the 99th percentile?
Well, certainly we see that in patients who come in very early after their onset of symptoms, but it's very uncommon. As a matter of fact, some years ago, even before the use of high sensitivity cardiac troponin, we did a study where we looked and asked exactly that question. And we found a very small number of individuals who had STEMI who didn't have an increase actually at the time that they presented, even if it was very early. And one possible reason for that is that there is a graded increase in high sensitivity troponin, which, as pointed out by many of us, is highly sensitive. Whenever there are risk factors, and most of the patients who have STEMIs have risk factors for coronary artery disease. So even if it's very early, often that's what you see, but it's quite rare.
Torbjorn, anything to add?
No, that is clearly my impression as well, that it occurs, but very infrequently. I think the general rule is more than 90%, I would say, will have increased troponin above the 99th percentile at presentation.
I guess the one other thing to say, Fred, just before we close with this, is there are situations where the ST segment elevation is not classic for STEMI. So there are mimickers and masqueraders that we need to be careful about. And so I wouldn't want our audience to go away and say, whenever there's ST elevation, irrespective of the clinical context, irrespective of what it really looks like on the electrocardiogram, that it's definitive, because there are a subset of patients in whom there can be so-called mimickers.
Thanks. We'll move on because I want to cover a couple multiple topics. Torbjorn, I'll start with you on this question. When regarding risk stratification, and you show some very nice Kaplan-Meier curves, when do you think that the risk hazard ratios or risk ratios will actually be starting to be reported on the medical record, on the electronic health record? So if a patient comes in, you show some very nice data. I know the data is assay dependent, but when would we actually put that risk data so the provider would actually see it when they're evaluating their patients? And what impact would that have as far as therapy?
Yeah, that's an interesting question. I think what we're moving towards is perhaps sort of artificial intelligence systems that will not look at troponin in isolation, but try to integrate it with other risk markers and then get sort of a risk estimate based on that. Because we know that troponin in a way reflect many other risk factors, and they are closely interconnected. So, we know that age, for instance, that cardiac troponins increase with age. We know that renal function is associated, or dysfunction is associated. So I think we probably will go in that direction.
Alan or Rick, anything to add to that?
Yeah, I do think it's important to emphasize that for each given disease entity, there may be a different slope for the risk curve, so that the idea that you could put one value in and predict all heart failure, all ischemic heart disease, all arrhythmias is probably not something that's going to be realistic, so that there will be different curves for each specific disease entity. And as Torbjorn has shown and sort of led the way with this, there will be substantial differences between men and women as well. So this could get to be a very complex thing to put into the EMR unless we're quite careful about how we do it.
Yeah, I think also it's a really good question, actually, because when patients come to the emergency department where I see them, We gather a load of information about them, so much more than the information that's required just to say whether they're having an acute myocardial infarction or not. And we have the data, just as Torbjörn nicely presented, that could actually get a really nice long-term cardiovascular risk prediction for them. So we rule out an acute myocardial infarction, but we know that patients who attend the emergency department with chest pain have a high, even ignoring the troponin, just because they came in with chest pain, they have a worse cardiovascular prognosis than the general population, because a lot of them got occult disease that we just don't detect. And that baseline cardiac troponin level, even in the absence of a myocardial infarction, could be pretty helpful to risk stratify people. Now, the people who come to the emergency department tend not to engage as much with primary care. There's a real teachable moment here for patients who come in. We could actually take an opportunity to identify, well, you know what, you're at quite long-term cardiovascular, you're quite a high risk of long-term cardiovascular disease. We can address some of the risk factors. We're doing a project on that at the moment. And in a busy emergency department, what's clear is that to identify cardiovascular risk, we have to have those processes automated, because in a crowded ED, it's just not people's priority. So, but we could use the EMR, we could use our informatics systems to identify that cardiovascular risk, just as the person who posed that question suggested. And then we'd need to identify some way of following up, communicating that effectively with the patients, ensuring they get the follow-up that they need to mitigate that cardiovascular risk. But I really think it's a really important and interesting area for future work.
Yeah. Rick, next question.
Fred, that's why I showed the slide from Martin Fan and Pickering. There is a graded relationship. The question is, you have to bin those by disease state, so somebody has to do that binning.
Yeah, I'll comment on my own work. We've had a study Utopia since the 2013, 2014, and others since. But when you have a database, let's say 6-7 years worth of data for, let's say, major adverse cardiac events and all-cause mortality, we've talked about making those hazard ratios available to the providers on a selected group of adverse outcomes, not each individual. Now, I move on to another topic. This one's directed to you, Rick. In your presentation, you generically talked about 0-1, 0-2, even 0-3, which I think now is kind of on the outs. But can you comment on the concept of, which you didn't really mention, the role of using a single presentation value rule out before you go to, let's say, a 0-1 or 0-2 hour? That's number one, or combine the two. And the second part of that is the concept of early presenters, because I know one of the criticisms of a 0-1 was missing early presenters. And if you look carefully, there's an asterisk, even on the 2020 ESC, that you have to be, I think, at least 3 hours out. A lot of questions. Let's try to keep it concise so we can get others in, but I'll give everyone a chance to comment on this.
Yeah, well, there's loads of evidence. I did have a slide on that with summarizing some evidence with the single test rule out. And there were those 2 RCTs loaded in historic, which studied it. I mean, there's overwhelming evidence that we can use it at the time of arrival in ED. Great question about time from symptom onset. Now, there's some data with the Abbott assay in particular from the Edinburgh group looking at time from symptom onset, which suggests that negative predictive value started to dip at less than 3 hours after presentation. Other areas, for example, in the loaded study, I don't think there was a threshold for symptom onset, and many of the observational studies didn't set a threshold. I think that, the guidelines say be cautious in the early presenters. So that's the answer. Be cautious in the early presenters. I go on a case-by-case basis personally. I combine that with my level of clinical suspicion, how early they presented, and I come to a reasoned decision. I wouldn't say never to rule out an early presenter, but I put all of the information together in doing it.
Thanks. Alan?
I think what the last thing Rick said is the most important. The technique does work. It's not perfect. No technique and no diagnostic ever is. But if you've got a thinking clinician who is inculcating the clinical circumstance, the likelihood of making an error with that is small. I will also note in the US, just to tout a manuscript that has just been accepted. The first author is by my colleague, Dr. Yoder Sandoval, that suggests that less than 6 actually works for the U.S. population in 86,000 patients evaluated at Mayo.
For what assay is that, Alan?
High sensitivity troponin T.
Okay, thank you. Torborn, any comments?
No, I can just echo what Rick and Alan said. So I think it has to be cautious, of course, with the early presenters, and maybe also making the point that the lab should, monitor sort of this when using the LOD. It is susceptible to drift or lot variation that should be taken into account, or that the clinician should be aware of.
Yeah, as a laboratorian, I think what your last statement is okay to say, but realistically, I would say that 999 out of 1,000 clinicians doesn't understand what you just said. And that's, I think it's good that you have a conversation with those that it's important to, but that's a tough laboratory message to get out. And I think what we have seen is based on numbers, even though there is some drift, the data holds up pretty strong down there, whether it's the limit of detection or that high stakes model, you have a slightly higher value that still meets, right, we'll say a 99.5% negative predictive value.
Yeah.
All right, another question came up, and I'm going to start with Rick on this because of his love of point of care. All right. It came out of the UK, actually, where the comment generally said it's really hard to meet a 60-minute turnaround time. That is even from the time the blood is drawn, by the time it's transported, the time it's spun, and you get a result. So there is some literature coming out on point of care high sensitive troponin I assays. I know there is not a high sensitive point of care troponin T. So you have experience, any thoughts on implementing a high sensitive troponin I assay into practice to alleviate the maybe slower turnaround times in many medical centers?
Yeah, this is a really, really hot topic. If you're in the UK, NICE doesn't recommend it. That's the bottom line at the moment. NICE looked at the Quidel assay. It was only validated in plasma, not in whole blood. We test in whole blood, so wait for the evidence from whole blood. It won't be too far away. The Siemens Italica VTLI will have evidence very soon. Fred Apple, in fact, published a very nice abstract from a big cohort of patients showing a very good sensitivity negative predictive value with a low cutoff with one single test. We need to validate that cutoff. The studies are about to start or even underway in some circumstances. So wait until later this year would be my advice. It's going to be a game changer, but we need the evidence, number one. And number two, even when we get it and you implement it, the work really won't stop there. Because if you want to get the benefits of the high sensitivity troponin and the rapid turnaround time, you're going to have to do a lot of work on your pathway to actually make sure that those results are acted on faster than you would get a lab result and make it cost effective.
Alan, any comments?
I think the one comment I would make, and it's apropos of the slide I showed about deciding what the pretest probability of disease is first. My concern is that if you're not very careful, the point of care values could all come back long before clinicians define what their pretest probability is. And that distorts the clinician's view once you know you have an elevated troponin or a non-elevated troponin. And so I think it's terribly important that we not cut out with the use of point of care, which I think will be beneficial in lots of ways, the clinical element that I still think will be very important.
Torborn, anything?
No, I think the limited data that have been presented by you are very sort of encouraging. And I think in Norway, we are also interested in validating those data. And I know Kristin Åker, who's also a member of the committee, is trying to get a multi-center study in Norway. So I think Rick's advice is very good, that we have to wait a little bit. And of course, as Alan says, put it in clinical context.
Yeah. Just from a laboratory point of view, I have been lucky to evaluate the Siemens VTLI point of care. It's a true whole blood assay. It's just like that iStat. You can slip it in your pocket. There isn't a lot of data published yet. We do have a derivation and validation cohorts that we're about to submit for a paper, but I can't say much because we're trying to get it published. But I think it will be this assay or any other assays that have a whole blood platform and start showing data will be potentially, as to quote Rick, game changers, and develop algorithms based on populations, whether it's in the UK, Norway, or the United States, depending on the patients we see, will show differences in rule out rates, both single and whether 0-1 or 0-2 hour. But I'm very encouraged. We'll just say that. So it'll be a huge improvement over the contemporary point of care assays that we know are not very analytically sensitive when people are presenting to the ER early. So one last question from the audience, and then I'll ask the group if they want to have any questions. It has to do with interferences. There was a question about concerns of interferences, protocols related to false positive and false negative results. And I'm going to answer that to start is as chair of our IFCC Committee on Clinical Applications of Cardiac Biomarkers, we have just drafted and are going to be hopefully submitting soon a paper addressing specifically macrotroponins with the concept of how do we recognize it, how do we have a methodology to test if it's there, and how do we provide interpretive concepts to our clinicians to deal with that. So it's a very assay-dependent interference, as well as other things like heterophile antibodies or other antibodies or HAMAs. But you have to keep in mind, and I'll in defense sometimes of the manufacturers, that when they're trying to, especially for troponin I or troponin T, when they're trying to figure out where the antibodies or capture and detection antibodies are, and they try to minimize some interferences, you can't minimize all of them because the interferences occurred at different locations on the amino acid sequence of the protein. So it is a challenge. Any of you three want to comment on, in addition to what I just commented on?
Yes, I think it behooves clinicians whenever the values do not comport to the clinical presentation of the patient to talk to the laboratory, because the vast majority of analytic confounds, whether they're false positive or false negative, are amenable to an intelligent approach that can detect them in the laboratory and correct those values. And it also will begin to give us evidence of how frequently these things occur. And finally, it's again this important concept that whether it's point of care or worry about an analytic confound, the clinical context has to drive what's going on. And if we lose that, which is my fear, as we move more and more rapidly with more and more this works, so to speak, sorts of numbers, that we could lose that.
Well, finally, there's a couple of last minute quick answers, which I'll answer, and you guys have a disagreement, you can go forward. First question was, which is better, high sensitivity cardiac troponin T or high sensitive troponin I? And my answer is yes, meaning that know your assay, they all work very well. There is no such thing as one better than the other. Any other comments to that one?
I think it is worth for the audience just to know that there are some differences. However, troponin T is more apt to be elevated in patients with renal disease. It's more apt to be elevated in patients who have non-ischemic myocardial injury as opposed to those with ischemic myocardial injury. And obviously, they all have different analytic difficulties.
If I can add, so I totally agree with Fred that, and especially in the acute coronary syndrome setting, it doesn't really matter. But there are, as Al says, interesting biological differences that actually translate in some also prognostic differences with regard to non-cardiovascular death versus ischemic events and so forth. But for the in clinical practice, I think they are the answer to the question is yes.
And the
Yeah, so I agree. Just to say, I wouldn't say one is better than the other, but you will notice differences. If you change from one assay to the other, you'll know differences, and you've got to learn the characteristics of that assay and how it behaves, and because they're all very different.
Yeah, generally my experience, and I've been fortunate to look at a lot of them, you maybe see a 90% concordance. So you're always going to be getting some positives, negatives between assays, and that sometimes happens when you even use different instruments around the cutoff in your own lab. Last question. Everyone gets a comment. Do you recommend sex-specific cutoffs for troponin I and or troponin T? We'll start with Torbjörn.
Yes, and I don't really understand. We are using it for several other biochemical tests, so it's unclear to me why there has been such a resistance.
Rick?
Well, the IFCC CCB recommends that we use them, so yes, of course. I mean, there's a good rationale for it. You do the reference ranging studies, there are clear differences, so that's the rationale for using sex-specific cutoffs. I think we still need to do a bit of work on how to optimize the use of the assays to identify what we really, what we really need, which is modifiable prognosis and something we can do something about. Probably a bit of work to do on that, and it might be that we need to personalize it even more than they're going further than sex. But yeah, the reference ranges are different, so yes.
Dr. Jaffe?
We know that there are differences, and we know that those differences are related to prognosis. We don't know yet is whether or not, if we move to not ignoring them, which unfortunately has been the rule rather than the exception, whether or not we can modify them. I suspect we can, and we should.
I'll just make one final comment on this, and then we'll close. It's endorsed by the 4th Universal Definition of Acute Myocardial Infarction, the 2018 last edition. And as a laboratory medicine community, both the American Association for Clinical Chemistry and our IFCC Committee on Clinical Applications have been endorsing this since 2015. So I think what manufacturers may recommend is different than what our global, I'll call generally global consensus is. It's not 100%, but clearly looking that way. And as Rick said, the data will speak for itself. And Torbjörn said the same thing. So with that, unless the 3 co-speakers have anything urgent they want to bring up, I will end this presently. And I want to thank the people behind the scenes who've had to deal with 4 very technical, one out of the 4 technically savvy people to get our presentations posted, and everyone got to see and hear us. And I'd like to thank the IFCC for the opportunity for us to give this webinar today. I will make one more commercial on the 26th of April. Our committee will have one more webinar on heart failure. You'll see it advertised shortly. It'll be chaired by Jordi Ordonez from Barcelona, Spain. So again, thanks everyone for coming. And I hope you learned one thing, and then that's a very positive thing. Rick, Torbjörn, Alan, thank you very much.
Thank you.